This is the Fix Your Sciatica podcast. Mobilization, movement, what happens when we combine the two. And today we actually have the opportunity to talk about combining both mobilization and movement with an expert in it in this technique, what is called the Mulligan method, Mulligan technique. And we're going to take a deep dive. And Dr. Eric Dinkins, who's a physical therapist, was kind enough to share his knowledge and education about the Mulligan method and how it can actually be applicable to patients or people who are dealing with sciatic pain like you listeners out there. So Eric, it was great seeing you, and thank you so much for being a guest on today's podcast.
Yeah, appreciate the invite. It's a beautiful day here in colorful Colorado, and I'm excited to be here. Thank you.
Yeah, the pleasure is all mine. So before we take a deep dive into the Mulligan concept, actually, let's talk a little bit more about yourself and the journey to where you're at today. Because I know that, the reason why I chose you or got referred to you was the fact that you know a lot about this. And I think that you have some sort of education company that actually goes through these concepts. So tell us a little bit more about that.
Yeah, absolutely. So I graduated with my physical therapy degree in 2001. So I've been treating clinically for a little bit over 20 years. I got my doctorate in 2017 in physical therapy, primarily in the outpatient kind of eclectic setting with rehabilitation. My first 5 years in clinical practice was a physician-owned practice who had the contract with the Broncos and the Rockies. So we had a lot of what would be considered, sports medicine early on. Saw a lot of knees, saw a lot of shoulders, a lot of non-operative and post-operative conditions. And then I transitioned over into more general eclectic practice since then. I have been a certified Mulligan practitioner since 2007, trained under Brian Mulligan himself when he was here in the United States, doing courses and explaining his techniques. And then I was introduced into the Mulligan Concept Teacher Association, which is an international teacher group, in 2014. For 8 years, I served as the secretary of the International Executive Committee for the MCTA. And I just recently stepped out of that role to focus on other things. And I am co-owner of MWM USA, which is the educational company that you were mentioning, which just is our marketing arm of how to bring people the knowledge base of mobilization with movement in the United States.
I love it. What a cool journey. So in the physical therapy world, or I guess like from my perspective, I like to say that there are the three big M's when it comes to pain management. We got McKenzie, we got Maitland, and we also got Mulligan as well. So the majority of the listeners have come across a lot of the McKenzie concepts. And unfortunately, a lot of people, when they think McKenzie, they think like, okay, just back extensions like every single day, right? And
sure.
The good news is that there's way more to that concept. Maitland, which I migrated towards, was really more so like looking into the patient, and like that's where we're looking at graded exposures and various different levels of mobilization itself. Tell us a little bit more about like the Mulligan concept itself and what kind of makes it what it is.
So to start, there's a lot of parallels with all of the techniques. People can kind of try to separate those out and say, well, we're really trying to achieve this, really trying to achieve that. I like to think of them in parallels because at some point in your career, you're likely going to use some aspect of each thought process with a particular patient. So you might as well see the similarities and then just understand some of the differences. From a standpoint of how mobilization with movement or the Mulligan concept is probably different the most from those other concepts is the ability to have people be involved in the decision making, have the symptoms be abolished during treatment rather than just reducing them or trying to centralize them. We're not super caught up in particular pathophysiological basis of what's going on as much as we are in the neurophysiologic, how the patient responds. And that's going to be the big focus. Brian Mulligan's first introduction into the concept that he developed was just the failure of a patient with other standard techniques that he was using, and then trying to get people to move at the same time he was applying forces across tissues, and finding that he didn't have to do things painful. It didn't necessarily, the outcome wasn't determined by what he would feel when he was doing joint mobilization. The outcome was most predominantly determined by how comfortable the patient was doing the thing that they couldn't do before. So, we can get into more detail as we go along with these questions. But ultimately, Brian was very interested in just immediately in real time changing the patient's symptoms to be able to do what they couldn't do before. And that probably separates him and his concept from the other ones most distinctly.
Great explanation. I'm glad that you share that, because I'm also learning a lot about the differences too. So I really appreciate that. One of the big things that I know that I focus on when I work with my clients, and I'm glad that you brought it up, is actually being able to make changes in real time. And I think one of the big challenges that patients with sciatica, or even just pain in general, when they go to a physical therapist, like I would say this is most of the experiences that clients who come to me say that their previous experience with other physical therapists say, I go into the clinic and I'm like doing all these exercises and I don't know if they're working. And what you're sharing with like changes in real time, I really appreciate that, because that's also how I practice too. Because, what I say is to patients is, when you're in an active state of pain, our jobs as physical therapists is to get you out of pain. And there's a lot of techniques, a lot of things that we can do to actually help us figure out, are there any changes in real time? And that's where you're going to be able to really, I believe, influence patients in a much more effective and faster way, because it helps us really guide our treatment. So thank you so much for sharing that with us. You brought up this concept of joint mobilization. So it's like joint mobilization with movement. We'll go into movement in a little bit, but tell us a little bit more about like what joint mobilization is. I've worked with or spoken with other manual therapists, and they have their definitions, but how would you define joint mobilization? And we'll talk a little bit more about the specifics.
Sure. I think it's important to dovetail off of what you just said there. And traditionally, this is a problem from a definition standpoint in skilled rehabilitation is, what is mobilization? Does it encapsulate manipulation? Does it encapsulate passive physiological motion? Does it encapsulate active arthro and osteokinematic motion? So mobilization, in a sense, can be a misnomer depending on how you're trying to define it, which adds to the confusion, right? I think most commonly, if we're applying a mobilization with movement, it's not the same type of mobilization that we've been taught in school to do a graded mobilization. It's not a 1 through 5. It's applying forces, accepting that we may or may not actually move joint surfaces on each other, applying forces that we may or may not influence the tissue that we think we're influencing. And so in that case, I'd probably say the Mulligan concept, when we try to define mobilization, it's a much more flexible definition of what we're trying to achieve. Again, that's not saying that different standards of mobilization couldn't be effective for different treatments. But mobilization is happening all the time. I'm moving my hands down here because I'm talking kinesthetically. Maybe I got a little bit of Italian in there with me, just kind of talking all the time with my hands in my genetics. But there's going to be a form of mobilization that I'm doing on myself all the time, because I'm actively pulling on all the structures that are connected into that movement. And then there's the processing component of that. Ways that I can take that away are going to be getting people on a table, positioning them, trying to get tonic stabilizer muscles to be as suppressed as possible, and then create accessory motions while I'm doing mobilization. And that's a very common way of an accepted treatment for pain or mobility. But really, all those are dictated by the clinician themselves. So you have a patient that's on the table, you do some assessment measures, and Ashley says, this is what I think is going on. I blind myself to your criteria and your treatment, and I go in there and I might find something completely different. I think both of those have value, whether we try to define an expert in the literature by definition or not. And so I think it's more of the understanding that mobilization is happening all the time, and whether the patient is in control of that probably needs to be assessed and then treated on an individual basis.
For sure, yeah. And so to piggyback, you brought up two key terms: physiological movement and accessory movement. And I know for me as a physical therapist, I know the big differences, but I think one of the challenges that patients might experience is that like they're PT or they're trying to go through and they're like, okay, accessory versus physiologic. Like, what's the difference between the two, or what are they?
Well, your physiological and accessory motions are going to be, accessory is going to be, I'm trying to just create movement over an area. I guess if we want to oversimplify it, just generalized, I need to get this thing moving. Physiologic is going to be, so this is the way that this probably should move or be moving in order to create normal function. So those can be completely different. Oftentimes they cross over, just trying to create accessory motion, perform some physiological motion. Doing a physiological movement will probably create some sort of accessory motion, depending on how you do it. Inherently, in most of our traditional joint mobilization techniques, there is some risk of both of those because oftentimes the patient is not in control of that movement. We're doing that for them. Now, the risk might be low, and as you gain some clinical experience and some street smarts, you start eliminating some of that risk also based on how you're treating the person. A lot of that for mobilization with movement kind of goes away because the patient has to report what they're feeling during the treatment, and therefore it protects the clinician in a way from not creating their symptoms. And so the patient's in control of both of those physiologic and accessory motions inherently in the mobilization with movement concept.
This episode is brought to you by the Patient Advocate Program. Are you tired of not having support between your rehab sessions? Introducing the Patient Advocate Program, and we're focused on your recovery, and we're offering you 24/7 access to a doctorate of physical therapy. Stop waiting in line to be seen and stop spending hours doing long exercise programs. Imagine being able to get all of your care delivered straight to your phone. Best of all, it's affordable. We believe everyone deserves top-notch relief without breaking the bank. So why wait? Take control of your health today and visit ptpatientadvocate.com and book your free call with our experts.
Very cool. And so listeners, to kind of visualize like what that is like, and this was actually what helped me understand a big difference between physiologic and accessory motions, is that, and unfortunately, like the current lay person education about joints themselves is a very one-dimensional, because say, for example, like our hip or our shoulder, they're like, it's a ball and socket joint, thinking that it kind of acts as, I want you to visualize like a door hinge where like you open a door and it's like, it's just pivoting on one specific axis. But the reality is that the door doesn't pivot on that specific axis. In some cases, that joint itself can kind of slide a little bit as we're going through. And I like to think about it as something along the lines of, and this is going to be like a really abstract image, but I think it was like the Mazda RX-3 had like the engine, which was like, it was like a rounded triangle within a rounded triangle. And so like it was spinning, but it also kind of sliding at the same time. And so you car enthusiasts out there, hopefully you've got that reference. But anyway, it was a cool visualization. And I really appreciate you, Eric, like sharing like what the difference is, and also understanding that like the reality is that we're not doing these things in isolation. Like they can be two separate things,
right?
But they happen at the same time. And I really appreciate how you said, if we go back into the dogmatic aspect where it's like it's one thing or the other, the reality is it could be a little bit of everything. And so that is something that I find to be particularly helpful and useful. So with Mulligan concept, we're putting the power, we're kind of sharing the power. It's not just placed on us therapists. It's a collaborative effort. We need to have patients tell us exactly what they're feeling so we can actually use that to guide our treatment. So when it comes to the Mulligan concept, and when it comes to dealing with something like sciatica pain, we'll call it like lumbar radiculopathy, we know that there are a lot of different causes and everything that can actually cause these radicular symptoms. So tell us a little bit more, with your background and with your training in this concept, talk us through kind of like what the assessment would look like when it comes to trying to manage something like sciatica.
Sure. I think there's going to be a standard approach, hopefully, with just your evaluative procedures from a standpoint of we need to get a very strong subjective. So a report from the patient in their own words about what they're feeling, what aggravates it, what causes it to improve. Can it be controlled with movement? Can it be controlled with medication? How far down the leg does it go? Does it follow a certain pattern? Do they present with the ability to define how it started? Was it just what we would call insidious? I don't know what I did, but just started happening, or was it a mechanism of injury? I would hope that everybody in our field is at least starting with some of those basics. Now, some people might kind of go a different route with some things that make them feel more comfortable. There's also assessing lumbar pain and radiculopathy is probably my largest time-framed exam that I will assess a person, because we have to assess the lumbar spine. We have to assess some tests of whether this pain or symptom might be coming out of the SI joint, sacroiliac joint, or whether the hip is contributing. And all those might be independent or collaborating together. Mostly that makes it a challenge because all those tests kind of overlap themselves in the literature and with presentation. So you can be getting buttock pain coming from any of those three structures. You can be getting proximal hamstring pain coming from any of those three structures. There will be some subtle differences, but you have to, in my opinion, examine all those to try to get a thought of what's most important to you as a clinician that you want to treat. Now, within the Mulligan concept, once we have a list of things that we think are of significance, including the patient's response, we would start trying to take away symptoms immediately in real time. So we follow what would be called the PIL response, which is an acronym for pain-free and can also be symptom-free, immediate response, and then turning it into long-lasting. Now, there's a lot of reasons or ways that you can modulate a person's pain presentation, but we want to make sure we are making good choices and we're moving in the right direction. So if a person is going to be what we would call a responder to a treatment, we want to make sure that their response is fully or partially permanent, and we make good decisions from that. If it's not, then we need to try to find something else that is doing that. And it kind of self-regulates us getting off the carousel of, I feel a little better and now I'm the same. I feel a little better and now I'm the same. You're just kind of going around the carousel. We want there to be a distinctive improvement for people. So to get back to kind of answering your question, the examination is probably, hopefully, going to be fairly standard for that area. But then what we would do with that information would differ.
I'm glad that you brought up, like, we hope that the evaluative process is a pretty standard thing when it comes to collecting the subjective, collecting the objective tests. I think one of the big challenges, again, when I've seen like clients who come to me or just experiencing other people's way of their recovery, is that they'll go in, they'll get asked these questions, and then they're like, okay, here are these like 10 different exercises for you to do. And I think one of the challenges in that approach is the fact that when you're just given exercise after exercise after exercise, well, actually, no. I mean, there are people who are really great at therapeutic exercise and therapeutic movement. The challenge is that when people are given exercise after exercise after exercise and not reassessing the effectiveness of that. And I think that was one of the biggest things that I've seen a lot in, unfortunately, a lot of clinics where maybe the clinician just didn't have the time, or just the way that they were brought up. They were like, okay, sciatica pain, hamstring stretch, piriformis stretch, maybe cobra for every single person. And obviously there are a lot of people who actually do get better through that process. But for the folks who might need a little bit more finesse, the approach that you're providing gives us an opportunity to be able to see like what's working, what's not. And I've actually started noticing, like, especially when I'm working with my clients, I get my subjective, I get my objective information before I actually even start providing any sort of treatment or intervention. I'll say, listen, based on what I'm hearing, I think it's going to be this area or this structure that's being affected. Like, these are the three things that we're going to try to work on. And then from there, again, like, provide an intervention, reassess how effective it is, and then move on from there. And then we give it. So it's like, it's this collaborative effort, which unfortunately with the way of how healthcare has gone, when insurance reimbursements are low or there's like a long backlog of patients, providers might not necessarily have the time to be able to put in that assessment to see if it's effective. And so for practitioners like yourself, I really appreciate being able to say, hey, let's see how we can change these, especially with that full response. So thank you so much for sharing that. I think it's huge when it comes to improving pain. So let's talk about some kind of like action steps in regards to the listener. Before we go into how to find like the Mulligan practitioner, or just like how to find a therapist who can help you figure it out. Because like pretty much pain management, it's not just like you go and you feel better. It's you go in, describe what you're feeling, and we're problem solving. I like to describe it as people like when we're working with someone, we're finding breadcrumbs for the thing that will actually get these patients better. So before we go into how to find a practitioner, tell us a little bit more like with your background and your knowledge. Let's talk about some like patient empowerment action steps in regards to like people who can either take care of themselves or like finding ways to improve their pain just like immediately. If there were like 3 action steps that patients can follow, listeners can follow, what would your recommendations be?
Part of the mobilization with movement approach is discovering with the patient, are there things that immediately make them better and increase their function right away? So inside the process of the evaluation, we go through a comparable sign list. So these are the things that bother you, are producing symptoms, something, and we will try to change those today. Every time I change something, I want to do a post test. So if I have a sciatica patient and they have limited hip internal rotation, they have a positive straight leg raise, they have pain that produces with an active movement going into flexion forward, I'm going to have to choose one of those things to treat. Most of the time, things can be reproduced by the patient themselves. So if you weren't even seeing a clinician, you could say, well, I have pain when I bend forward. Well, what happens if you put your fist on your back and you kind of lift up and then you bend forward? Oh, I can go much further before I get my pain. I think you should actively start moving without your symptom and bend forward, because I would do that with you as a clinician in the exam room. But then I'd have to go back and I'd say, well, now that you moved further, now let's look at your hip internal rotation again. Let's look at your straight leg raise sign and see if anything has changed in those as well. So kind of to your point before, if a clinician doesn't have the time or they're fearful of doing a particular action because they might hurt themselves, if they don't have their symptom, that is a huge emotional and cognitive benefit to reducing kinesiophobia or the fear of movement, reducing catastrophizing, which would be, well, if I go further, I'm just going to keep hurting myself worse. We want to try to eliminate those. I think a good majority of my patients that I see have already kind of figured these out. They just don't know how to complement that. So if a person was doing like a Zoom call and they say, well, I have pain when I go to lift my arm, I have pain when I bend forward, whatever it is, we could probably still triage that from the sense of, well, what if you kind of lifted up on your neck, or what if you lifted up on your back, or what if you pushed your knee to the side but stabilized with another hand? Does that make that feel better? And just the response would tell me if I want to treat them that way or not. And so it's always a good thing to have active movement without your symptoms. You're likely not going to run into very many scenarios of you would be somehow hurting yourself and not knowing it. I mean, you'd have to have probably some sort of pain shutoff switch in your brain to not have that, come back, or it was incredibly masked with pharmaceuticals, which is a detriment for pharmaceuticals for sure. If you are masking your pain response, you might not be getting the relay to the brain to tell you to not do that. And oftentimes that's just a false signal anyway. And so the inherent in the mobilization with movement approach is, if we can have you do something and have a symptom produced, we would try to eliminate that so we know it's safe to move. And this is probably not from some sort of structural restriction, but maybe some just sort of processing thing that the brain is being very protective of. So the encouragement with my patients is going to be, if we can make a change, we just need to keep that change from coming back. If we improved your straight leg raise with your sciatica, I just need you to keep doing this and then creating that motion that you don't get your straight leg raise sign. That would create improved neurodynamics, decreased emotional fear about their pain, maybe even start questioning whether their back problem is actually a permanent issue or a manageable thing over time. And so empowering the patient to be able to take care of themselves has to be a critical component of care. But whether it's with a mobilization with movement approach or not, if a person came in to take the same scenario and I gave them an exercise for their hip and that improved their intra-rotation, they said, my leg raise is better. Well, then let's just do that exercise. It's already making you better. It's decreasing your comparable sign. And a straight leg raise test is a highly sensitive test frequently in the literature. So for listeners, it gives us a sense of, negative tests are ruling things out. And so if you have a positive and we turn that into a negative, we start ruling out some nefarious things. That's a very powerful thing that we can do. Or said differently, minimizing the false negatives. We want this, most of our tests to be negative, at least as a reason for discharge, right? So that's kind of a long-winded explanation of empowering the patient. But most MWMs, there's something that the patient can do to treat themselves, to turn off their symptoms and promote motion.
Huge. I think it's really important. And thank you so much for sharing that. And as you were discussing, there were a couple really important themes and concepts that really popped up. I think number one was you can actually change your symptoms. And when it comes to changing, and we all wish that when it comes to changing, that it's just a light switch, right? Whether it be it's there or it's not. For many times, it's more of a sliding scale in regards to, okay, you do this, it's less pain, or you do, or you're you do it and it's less painful, you have a little bit more range of motion. It's important for us to actually be able to look at the general theme of things. So say, for example, if bending forward and touching your toes was painful, the questions we have to ask was well, how far can you touch your toes before the pain comes on? How intense is the pain? Where is the pain distribution? So there's a lot of questions that we can ask, or a lot of descriptors that gives us an opportunity to see, is there a positive change? And the great thing is that there certainly are techniques or exercises that allows us to experience that on and off switch, to be able to reduce the fear, reduce the pain, or abolish the fear, abolish the pain. And I really appreciate that. And oftentimes that makes me think, all right, well, it gives us an opportunity to change how we do things versus just what we do, right? And I don't think that we as a community, or even just as a society, have forgiven change how you do things versus change what. We haven't really given that much of an opportunity, except a few practitioners such as yourself and myself as well. So I'm really, really thankful that you put that in. And then the concept of pharmaceuticals can actually mask symptoms, which gives us somewhat of an inaccurate representation of what's going on. Is what we're doing actually going to be beneficial to us? Or on the other hand, is it going to be a little bit more irritating? We just don't know. And I see this a lot in patients who say, for example, get an epidural injection. I think that there's a lot of value in epidural injections. It actually allows them to move a little bit better. But what I'll see in the Reddit message boards, they're I got an ESI and my pain was good for about 3 weeks, but then I'm back to normal pain. And the reality is the fact that the reason probably why they got back into what their previous pain pattern, it wasn't the fact that the ESI didn't work, but if they had the injection, but then they changed nothing about how they went about doing their things, they're probably, again, their symptoms were masked. They were doing activities that were a little bit more irritating, hence the short acting level of the injection itself. So thank you so much for sharing that, because it often gets overlooked, and then people look at and then people perceive it as, oh, said technique didn't work, it was ineffective or caused more pain. And so thank you again. And so, which then brings us to the next question. It's going to be a two-part question. Is going to be, how can patients find a practitioner that will actually be able to spend the time to take care of them? That's going to be number one. The second part is if we're looking at Mulligan concepts specifically, how do we come across practitioners such as yourself? But let's talk about the first piece in regards to having the time, having that opportunity to be able to say, are things working? How can we find the practitioner that will be able to do a pre-test, intervention, post-test? What are some of the characteristics or things that patients should be looking for during their search for a provider or physical therapist, chiropractor, or something like that? Sure.
Well, I think that's going to be a challenge, because we don't have any necessarily screening tool besides word of mouth in the community, which makes it super important from a practitioner standpoint to refer themselves essentially through success. And of course, success is defined by the patient, not necessarily by us. But you're going to have to find somebody who's willing to sit down and let you tell your story as a patient, listen to your story, ask questions. Most importantly, respond with other questions and trying to figure out. Nobody hopefully wants a person to come in and say, so I have a piece of paper here that has my diagnosis on it, and let's just go ahead and write into treatment because of whatever was written on a piece of paper. We have to go through a process of determining whether the subjective and the special tests, which are really not that special, right, kind of frame where we want to treat. But then you have to be able to have some sort of retest. If we give a person a sheet of exercises based on sciatica, and you mentioned some of them that are probably super common before with stretching and some other, basics, they could be very good, or they could make no difference, or maybe even be an irritant. So hopefully a patient would go into a practitioner and say, so you've come to a conclusion, what do we want to do now? And the practitioner says, well, let's do some bridging exercises. Well, how do we know that's going to be effective besides just do them for a while and let's see if something changes? We would say, well, do a bridge, do them a certain number of times based on your sensitivities and irritabilities and what we think is going on in the underneath tissues as a hypothesis. And now before, you had pain with walking and pain with extending your back and standing. Well, do some bridges and let's do those two things. How does it feel to walk now? Well, I think that feels actually a little bit better. What's better about it? Well, it doesn't go down into my hamstring anymore. It's kind of up in my back. Well, that's a valuable thing for us. That sounds good. If you do 5 things, and if you're not familiar with rehabilitation, these will just be common exercises. If I have a person walk on the treadmill for 5 minutes, do some bridging, stretch their piriformis, if that's possible, do some nerve mobility things with sliders or tensioners, and then do some sit to stand squats. And then I do my post test, if you at all we're going to do it. Let's say the post test was worse. You don't know which exercise made them worse. You don't know if it was your tests. You don't know if it was the treatment. You don't know if it was them behaviorally having an emotional response that they're just reporting more or less of their symptoms. And so as clinicians, we just need to be willing to say, I'm going to treat you with something and then see if I'm accurate. The only way we can see if I'm accurate is the patient's report and our tests. So we need to redo a test. The pre-test, post-test design, everybody, I think, in the rehabilitation world understands it, but people oftentimes glance or skip over it because they don't want to seem like they don't know what they're doing. We need to gain some confidence as clinicians to say, well, the tests and your report were telling me this, but when we treat you kind of classically for this, or we attempted this, that didn't go as well as I had hoped. So between now and the next time, I want you to do these things because those are things you told me were controlling your symptoms anyway. Or if you don't have those, you can just encourage a person to stay physically active as much as they can. And I'm going to keep plugging away at this to next time, see if we can try different things to get a better response. Go ahead and offer up to your patient that it's my job to figure out how to get you better the fastest, and not rely on some sort of predetermined bias or a conglomerate of exercises or activities that aren't working for you. And that would be, again, inherent in the Mulligan concept. I think that's hopefully inherent in some other concepts as well. We just maybe approach it a little bit differently on how long we're willing to wait on a symptom to resolve based on some of those bias and tests. So hopefully that kind of makes some sense to some of your listeners there.
Yeah. And I think what's important, especially with, and this is what I believe, and I'm in 100% agreement with you, when you're dealing with pain that isn't, say, like due to a fracture or due to a surgery, and if you're dealing with some sort of pain, say, for example, like sciatica, and we really haven't had the opportunity to really pinpoint what the structure is, because even the diagnostic accuracy of an MRI, I mean, MRIs are great, it helps us detect cancers, cysts, and all that stuff. But when it comes to actually identifying like the source of your pain, there is a huge limit to MRIs. And so it's a problem solving process where we have to figure out what's working, what isn't. And listeners, I encourage you, when you are looking for, or we're working with a provider, evaluate, is your provider asking you, like, how are things feeling? Or like, how does this change? Or asking you all these follow-up questions. because that's where the true problem solving begins. We can figure out what can actually improve. And I find that, especially through my experience, when you're dealing with something like sciatica pain, you don't need 50 different exercises to actually get yourself better. In fact, in some cases, it's only maybe for a good amount of cases, it's one thing that patients need to do. In other cases, it may be like 3 to 5, like daily practices that patients need to do. And yeah, I'm in agreement with you, Eric, that we need that there needs to be more problem solving versus here's this diagnosis, here are these things for that specific diagnosis, which then actually brings us up into like the crux of this conversation, which with Mulligan Concepts, right? Now you have an education company. Mulligan itself has their own certifying body. If listeners are out there trying to figure out, okay, I think I want to work with a Mulligan practitioner, what is the best way for them to actually?
So if people are interested in a very, very specific technique, you can go to B as in Brian, Mulligan.com, bmulligan.com. There's a tab on the top of that website that says find a practitioner. You can click on that, drop it down, put in your country of origin. You can put in your state of origin, and you'll get a list of all of our certified Mulligan practitioners in your area. I field probably one contact a month, either phone or email, where people are, hey, I got so much impact from this technique. My mother lives in Florida. Who can I have her refer to in Florida that would take this same approach? And that's how we triage those. So you can contact us directly on the mwmusa.com site. You can go down to the bottom and say, contact Eric. There's a new Con Ed company that's coming up in 2025 called Inspire Con Ed, all one word. We're bringing that up, which is be more of a eclectic approach to education. People like yourself could contribute on that type of platform to different online or live courses. And they could contact us through that, or go to the bmulligan.com, which is the international one. But the international site has the full list of all certified Mulligan practitioners. And that doesn't guarantee anything. It just shows competence in our particular concept. Hopefully that practitioner would be open-minded as a treatment professional to say, this is either going to help you or it's not. And if it's not, I'm going to find something that does. So it's a place to start, and you can go from there.
Listeners, I'm going to go ahead and put those links into the show notes. So if you didn't get a chance to write that down, you can just click on it for the description. Eric, this has been extremely helpful and eye-opening. I'm glad that we had the opportunity to talk a lot about this subject, and I'm a huge fan. For the listeners who are out there who are like, I think I have a couple more specific questions for Eric. What's the best way to get in contact with you?
So you can go to Eric D, as in Dinkins, my last name, at mwmusa.com. That can send me an email directly. You can also use my personal, which is my last name, Dinkins7895 at msn.com. If you want to contact me directly with questions, find out information about courses, find a practitioner, I can help take you through that process if you just need to find somebody who's willing to treat you like this. Yeah, I'm always welcome to that. Very few people abuse those privileges of contacts. And so hit me up on email. I'll get back to you as soon as possible. You can also go to the website and hit that contact button that I mentioned, and that'd be a good one. So however people need to get a hold of me.
Awesome. Eric, thank you so much for your time. This was really, really great. And listeners, again, his contact information will be found in the show notes. So Eric, thank you again. It was great to see you.
Ashley, appreciate the invite. Have a great rest of your day.
Thank you so much for tuning in. We hope you got some help from today's podcast. And for more info, check us out at ifixyoursciatica.com. Have a fantastic and pain-free day. No patient-therapist relationship is formed by listening to this podcast. We are not providing medical advice, and all information should be confirmed by a medical provider.